the organizer, and Dr. Sabo for the invitation to be here. It's always a pleasure for me. So today I will talk of the impact of pancreas and liver crosstalk on insulin glucose metabolism, diabetes, and non-alcoholic fatty liver disease. And these are my disclosure. So we know that diabetes, it's really an important disease, and also that it's not that the prevalence and the incidence is not stopping. Actually, it's increasing, and we expect an increase into the, let me see if I can put the marker, the laser pointer, here it is. So we will have an increase, expected increase of 51%. Due to many reasons, the type of diet, sedentarity, but also we have genetic predisposition. It's also important in the Asian country where the increase is expected to be 74%, so much higher than the average world increase. And also it's important because it's associated to obesity and also to other metabolic diseases like a non-alcoholic fatty liver disease that we were talking about just a few minutes ago. So NAFLD, the fatty liver disease that is starting with accumulation of fat in the liver, is now the most prevalent metabolic disease because the prevalence is 1 in 4 person in the general population. And you can see here there are continents where it's even higher, like in South America or in the Middle East. And NAFLD, it's important also because it's associated with a 2.2-fold increased risk of developing diabetes. And the prevalence of NAFLD in diabetes is doubled compared to the general population, so it's 55%. And the global prevalence of non-alcoholic steatohepatitis, that is already in a progression of a disease, it's about 37%. So 1 in 3 persons subject with type 2 diabetes will have not only fatty liver, but also the steatohepatitis with fibrosis that could be advanced to cirrhosis in 17%. So this is also important because this disease is completely asymptomatic. So when we are talking before with Professor Massi Benedetti that the first things to ask a patient is, how do you feel? They cannot feel NAFLD. Usually, you know, the most reported feeling is fatigue. So it's something that is not even considered symptoms. And the prediction in 2045 will be that 388 million of subjects will have NAFLD and diabetes, and 261 million will have NASH and diabetes. So I want here to go through the natural history of type 2 diabetes and showing you how it is related to fatty liver disease. So we know that insulin resistant is the major characteristic of a subject with diabetes, and there is a decline in sensitivity and development of insulin resistance, but it's actually diabetes and hyperglycemia develops only when our pancreas and the beta cells cannot secrete enough insulin to overcome this insulin resistance. So the hyperglycemia develops only when the pancreas that starts secreting more insulin, that at a certain point becomes exhausted and the amount of insulin goes down. And at the end, you really need also insulin as a treatment in order to treat hyperglycemia. And the liver plays a central role in the maintaining glucose and lipid homeostasis because not only the liver is the major organ that is also produce endogenous glucose and is producing gluconeogenesis and is also producing lipoproteins. So it's important also for our vessel and the comorbidity of diabetes. And the lipids are mainly, the lipids that are coming to the liver either from the meal or from the lipolysis, they are coming to the liver. They are made as a triglyceride, reesterified to triglyceride, as triglycerides are exported as a lipoprotein, initially as VLDL, and then the VLDL becomes LDL, and then we have finally the HDL to go back with the cholesterol. But when this amount of fat is too much, the triglyceride cannot be exported and the liver becomes steatotic. And from steatosis, we go to inflammation and eventually to the scars, that is the fibrosis, and the activation of extra cells that are not only hepatocytes in the liver, but there are also Kupffer cell hepatic stellate cells that are related, involved with inflammation and in fibrosis. So now, NAFLD is associated, as we said, with a 2.2-fold increase. So the progression of NAFLD is also, how is this associated with the progression of the risk of diabetes? As I told you, starting with steatosis, is going to steatosis, inflammation, and that is NASH. And then after NASH, we have a starting or during NASH, there is initiation of a fibrosis. That is a mechanism that is sort of a repair mechanism. And we know also the insulin, the excess insulin that is so common in insulin resistant state and is also metabolized by the liver. It's also a pro-collagen synthesis. So it's also increasing the process of fibrosis. That could, at the beginning, could be a good mechanism, but then when it's becoming too much and there is a progression to different levels, the liver can even become cirrhotic, and this is very bad because it's a higher risk of hepatocellular carcinoma, and right now NAFLD is the major cause for liver transplantation. But we have good news, because the remission of type 2 diabetes is also associated with the decrease of fat in liver and pancreas, because also pancreas can accumulate fat. But this is only if the beta cell can be recovered. That means that if the beta cells are still active, then by diet, in this case, this is the famous study from a direct study that was led by Roy Taylor in Newcastle, when you have a decrease in beta cell in the liver, in fat and pancreatic fat due to the diet hypocaloric, then you can have a recovery and even a remission of diabetes. So diabetes, as I said, it's a balance between insulin secretion and insulin action. And this is measured as a disposition index. So as the subject was becoming more insulin resistant, so we go on this side, there is a higher need for insulin secretion. But then, as I said before, when there is not enough insulin secreted, the subject from normal glucose tolerance becomes in IGT, impaired glucose tolerance, or diabetic. So is NASH risk for type 2 diabetes due to the reduced beta cell function? Because we know that NASH is an NAFLD associated with insulin resistance. So this was the first question that we asked ourselves, and I will show you some of the data that we have published. So we use the oral glucose tolerance test, because the oral glucose tolerance test with the measurement of not only glucose, but also insulin and C-peptide allow us to measure the glucose excursion and indexes for insulin sensitivity, that is mainly muscle, and also insulin secretion, and calculate this disposition index. So first, I wanted to show you some data in a subject with biopsy-proven NASH, where they are all non-diabetic. But this is important because when we divided the subject according to the level of steatosis, these are the 3 levels of steatosis, steatosis 1 and 2, and the most severe 3. And we also divided the subject among those with a BMI below 30 or above 30. We observed that it was very unexpected, actually, that the curves were really superimposable regarding the glucose excursion. And these were, as I said, all non-diabetic, only a few of them, they had the IGT. But the insulin was much higher. The lowest one was the non-obese with the lower steatosis, and that are the less insulin resistant, and all the other one had a high insulin. Then we did, so then we did the same subject, where instead divided according to the level of fibrosis and obesity. So those with low fibrosis, fibrosis less than 2, so fibrosis 0 and 1, they had a lower glucose excursion compared to those with higher fibrosis. But the curves were really very similar as when the subject were, these are the same subject, are not different subjects. So you see here that having fibrosis is associated with a higher glucose excursion. That was very, very unexpected, because why scars in the liver should be, but not steatosis, should be associated with an increased glucose excursion. So we went on and we look at the insulin response, measuring the increase, the relative increase in insulin to glucose, and we saw no difference among the groups, 0-1 of fibrosis or fibrosis 2 that is intermediate to this one that is pre-cirrhosis and cirrhosis, fibrosis 3 and 4. But then we found that this subject with higher fibrosis had a reduced OGS, that is the index of peripheral insulin sensitivity. So actually, this is all explained by muscle insulin resistance. So those with high fibrosis, they also have muscle insulin resistance. So is something related to this or not? So we look, if OGS or insulin sensitivity and secretion, where also we could find these things about the fibrosis also in other liver disease. And we look also subject with the hepatitis C virus with genotype 3 that is associated with steatosis as well, or hepatitis or genotype 1 and 2 versus NAFLD. And you see all these subjects were not really obese, they were of course overweight. And as expected, the one on NAFLD were a little bit higher weight and a higher BMI. But look at the curve here. So these are the normal glucose tolerance without liver disease and with insulin sensitivity. And all the subjects with chronic hepatitis C, insulin resistance without liver disease or NAFLD, they have similar glucose, but actually those with the NAFLD have a much higher insulin levels. And while the other one had a very similar insulin levels. So when we look at the OGS and the insulin secretion response, so this is insulin sensitivity and this is the insulin response, we found that the insulin sensitivity was much lower than the reference group, that is the yellow one, in those with NAFLD, was very similar or a little bit higher in one with hepatitis C. So the hepatitis C did not have insulin resistance. So having liver disease doesn't mean having insulin resistance, but having NAFLD is associated to insulin resistance. But those with hepatitis C, they had a reduced insulin response, while the one with NAFLD tended to have higher insulin response than the NGT. So the disposition index showed that the NAFLD, so that is also the risk of type 2 diabetes, was not diminished, but was actually increased in those that remain normal glucose tolerance, and there was decrease only when they were becoming IGT. Instead, in insulin resistance without liver disease or the chronic hepatitis C, there was already a reduction in the disposition index. And here you can see it by looking at the hyperbolic curve, that actually compared to the NGT sensitive that are here, the NGT NAFLD, they are actually on a better condition according to the disposition index compared to the reference group. So impaired beta cell function increase insulin resistance favored, we know, the development of hyperglycemia, but NAFLD per se is not associated always with a decreased disposition index, because you can see here the results. But when we look at the fibrosis, and so we look at the chronic hepatitis C and the NAFLD, you can see that insulin sensitivity was similar in, and actually much higher in chronic hepatitis C, and tending instead, again, also in this group, to be lower with the high fibrosis, and also with a decrease in NAS score that is the sum of inflammation, ballooning, and the steatosis. And the insulin response was instead, as I show you here, that was not also associated to the liver fibrosis in none of the group. So liver fibrosis, we know, is important because it's the most important predictor for liver-related mortality. But actually, we cannot say that, but we also have to say that it is also probably associated, is a marker, if not a determinant of type 2 diabetes. So in the liver-pancreas crosstalk, another important part is that the liver is also the site that is clearing the great part of the insulin that is secreted by the pancreas in the portal vein. So on the first pass, we know that there is 60 to 70% insulin degradation. Then the insulin goes in the hepatic vein. It is going back to the circulation to go to the different organs, and then is recirculating back to the hepatic artery. So in total, we can say that the liver is the organ that mainly metabolizes insulin by not only internalizing and activating the receptors, but also by degrading it because it's more than enough the amount of insulin that is secreted by the pancreas. And the disruption in this also in the liver pancreas crosstalk is a major risk factor for type 2 diabetes. So here we can say that the insulin clearance from the epidemiology, and we can see here with the NAFLD and diagnosis and progression, insulin clearance is decreasing much in a lower rate compared to insulin sensitivity, but is also contributing to the fasting hyperglycemia. So how do we measure insulin clearance? We measure it using some the C-peptide and some modeling. I'm not going to go into this, but what we found is that the insulin clearance was inversely associated with insulin resistance in the adipose tissue, in the liver, and in the muscle, and much more with the liver in the muscle than in the liver or in the adipose tissue. And another important thing is how insulin secretion and clearance is modulated during the response to an OGTT. So, for example, here you see the non-obese subject. In black, they are the NGT. In square is the IGT, and triangle, they are the type 2 diabetes. You see that in response to the OGTT, you have an increase in insulin secretion because, of course, there is an increase in glucose. You need to decrease the glucose, and the glucose is much higher in the IGT that requires more insulin, while the diabetic have a defect in the secretion. The obese, they secrete more insulin because they are more insulin resistant. So you see here that they have a higher insulin secretion, but again, the diabetic have a reduced and impaired insulin secretion. The insulin concentration are therefore similar to the insulin secretion that are derived from C-peptide, while this one is a measurement post-liver. But the question is, how is the clearance? So how is this is pre-hepatic insulin secretion. So this is the effect of the post-hepatic insulin secretion. We want to look how is the clearance of the liver. So how the liver is behaving. Sorry, I did something here. So this is the insulin clearance, and this is the hepatic insulin extraction. So you see that the diabetic, they did not change their clearance, so there is no effect, while the NGT and IGT, they reduce the clearance. That means that this is despite a higher insulin extraction, but this is allowing more insulin to go to the periphery, because it's like the liver is opening the gate to let more insulin, less insulin percent of insulin into the liver and more insulin into the periphery. So how is insulin secretion and clearance in NAFLD? We know that patients with NAFLD have higher insulin, and this is because of high insulin secretion and reduced insulin clearance. I'll show you the results. These are some of the data presented by, published by the group of Professor Klein, that show that the lean NAFLD had an hepatic extraction of 70%, considering the amount of insulin that from the pancreas is secreted. The obese NAFLD, they have a similar hepatic structure, but of course it is much more because there is more insulin here. And the lean non-NAFLD, these are the obese non-NAFLD, and these are the obese NAFLD. The obese NAFLD have a reduced clearance, so they have much more insulin in the periphery because not only they secrete more insulin, but also they clear less. So this is why they have a more increase. And also they also have a saturation of the hepatic structure. So we wanted to show the progression, and we studied 340 subjects that had liver biopsy. And so we had not only the different degrees of tolerance, but also different degrees of liver fibrosis and NASH. And we wanted to look if there was the abnormalities. And here are the curves. Probably you are more familiar with the curve that with the biopsy. So you can see here the NGT, they had no NAFL in blue and NASH in red. They have the similar glucose excursion, although the NAFL and NASH had a little bit higher glucose and higher insulin. Same things for the IGT, and all the IGT had a higher glucose as expected than the NGT. And in the type 2 diabetes, the NASH had the much higher glucose excursion, and also but the insulin in this case was reduced, but not as much as in the other group I showed you before. So when we look at the insulin concentration, also regarding the NASH with different fibrosis, you see here that the insulin concentration in each group are much higher in those that they have NASH fibrosis 2-4. So this is quite interesting. Also, the pre-hepatic insulin rate was also much higher. And the insulin clearance instead is much lower. So look at this. As we expected, there was a decrease in insulin clearance, but this was in this group of subjects with biopsy-proven NAFL or NASH. The decrease in mean insulin clearance during the OGTT was more related to the amount of fat in the liver and to severity of liver disease than to the real glucose tolerance, because you see NGT, AGT, and type 2 diabetes without NAFL, they have a similar clearance, and they have similar mean insulin that is much lower, and they have a similar insulin secretion rate. Of course, you know, when you become diabetic, you have also much likely is there more subject with NAFL and NASH than in the other group. But this is very striking because this means that the liver disease in diabetes has been neglected, and instead it's important not only because of the liver disease of the fat metabolism, but also for the glucose and the insulin metabolism. And when we look at the clearance with
Dr. Amalia, sorry to interrupt, but we have, yes, great, thank you.
I'm finishing. This is the last slide. So you see here again that there is a decrease in clearance with NASH fibrosis, and also the OGS, that is the insulin sensitivity, is much lower in those with fibrosis, as well as the disposition index that goes down from NGT to IGT to diabetes, but much more in the NASH with the fibrosis. So in conclusion, the liver fibrosis stage is not only the most important predictor of liver-related mortality, but also associated with a worse metabolic profile, even at mild stage. And with this, I'm concluding also because insulin is probably acting also not only hepatocyte, but also on the Kupffer and hepatic stellate cells. And I think these are the next challenges for the next years. So I'd like to acknowledge our sponsors and the grants at the European Union. Thank you very much for your attention.